We've been hearing a lot lately about doing molecular profiling or next generation sequencing for patients with both colon cancer and other types of advanced cancers. I personally am a proponent of doing next-gen sequencing for patients with metastatic colorectal cancer because you can learn a lot of things. First of all, standard of care to know the expanded RAS analysis, to also know BRAF analysis, but also we need to learn about microsatellite stability or instability, which can be done on next-gen sequencing or other molecular platforms. But also now we're starting to find subtypes of patients, including HER2 positive patients and other types of mutations where we may have other targeted therapies or there may be clinical trials available for those patients to see if other targeted therapies may work.
When we look at all the GI cancers, for example, and we put MSI high and tumor mutational burden, they seem to be somewhat overlapping. In colorectal cancer, they overlap pretty nicely, almost 90-95% overlap. So what that tells us, about 90%. So what that tells us is MSI high is essentially just a surrogate marker for tumor mutational burden. So its presence, MSI high's presence, only tells us that the tumor is loaded with a mutation. It doesn't necessarily predict for who may or may not respond to immune therapy. Tumor mutational burden just tells us about how heavy is the tumor mutational burden is in a tumor. The higher it is, the more likely the tumor will respond to immune therapy agents such as PD-1, PD-L1 inhibitors and the combos. It appears that the tumor mutational burden is higher on the left side in the presence of MSI high versus on the right side for whatever reason. That's a bit unclear, although these are preliminary studies. But overall, it is safe to say that MSI high is a good surrogate marker for tumor mutational burden. Now, that said, not every patient with a high tumor mutational burden will have MSI high, or vice versa. So that's very important to keep in mind. And we're relying more and more on the tumor mutational burden, TMB, to define who would be the best candidate for immune therapy. Because again, it just tells you that how loaded is this tumor in terms of mutations and how more likely it will be to respond to immune therapy agents. We're not where we should be right now. So think about the landscape in first-line metastatic colorectal cancer today. Most patients in the United States will be treated with chemotherapy plus bevacizumab. Some would switch the bevacizumab for an EGFR inhibitor. And that's based on essentially all the data we've had without the presence of a good predictive marker. For bevacizumab, we don't have a predictive marker. We essentially treat everyone to benefit many, but not all. With EGFR inhibitors, we're starting to learn a little bit more about who should not get it. We don't know how to select for those who should get it. So we have a negative predictive biomarker, not a positive one. Positive are the ideal ones because they do select better. So we know that, for example, in the presence of a RAS mutation, of a BRAF mutation, of a HER2 amplification, those patients will not benefit from an EGFR inhibitor. We know that the right side, as we understand a little bit more the molecular origins of why, on the right side, there is no benefit from EGFR inhibitor, at least in the first line, maybe in the second line. So we have some of these predictive biomarkers. We're learning that HER2 amplifications may predict for response to HER2 targeted therapies, and many are under development. We also understand that MSI high or tumor mutational burden high tumors will respond to PD-1, PD-L1 inhibitors, and we know that. So we have few predictive biomarkers. For the majority of the patients, though, we don't know. We just have no idea why bevacizumab works or doesn't, why other VEGF inhibitors work or not. We don't know why chemotherapy works or not in some. We don't know why regorafenib works in some and not in others. We don't know why TAS-102 works. And we certainly continue to explore the intricacies of other molecular or genetic drivers of the disease so we can target them better. We're getting better overall. 10 years ago, we didn't have almost any predictive biomarkers other than KRAS. That was it. That was the only one we could use. Everything else was just unselected. So we're doing better, but we're far from where we should be. We're on track to understand a little bit more additional predictive biomarkers that will break down this disease into multiple pieces.
So now, as we're doing more next-gen sequencing of patients with advanced cancers, we're learning about different subsets of these patients and potential treatment options for them. For example, we know for patients who have RAS mutations, we shouldn't be using anti-EGFR antibodies because these probably won't work. For patients with BRAF mutations, we probably want to use some sort of combination of an EGFR inhibitor and a BRAF inhibitor, and in fact, NCCN guidelines recommend second-line use of cetuximab plus irinotecan plus dabrafenib for patients with BRAF mutated colon cancer. We also know in the first-line setting for these patients, a combination of FOLFOXIRI plus bevacizumab may be more beneficial for them. For patients with HER2-positive disease, which accounts for about 5% of patients, there is some suggestion that these patients may not respond to EGFR inhibitors. But possibly more importantly, we've seen some preliminary data that suggests they may respond to combinations of anti-HER2 agents, like trastuzumab plus lorlatinib or trastuzumab plus pertuzumab. We're also very excited about NTRK fusions. We've seen these in multiple types of cancers, and in colon cancer probably accounts for about 2% of patients. But we now have NTRK targeted therapies for these patients that might be potentially beneficial to them.